Welcome back to the San Francisco County Ambulance District's COVID-19 Patient Management Series. In this video, we will demonstrate the management of out-of-hospital cardiac arrest. There have been some minor changes to the source control hood since the original recording of this video. We now suggest that the clear sheet be pre-assembled and attached to the PVC with the provided clips. This is to aid in a more efficient and safe deployment. Note, these two clinicians have decided that one will perform patient care while the second takes a support and setup role. That is an option. So as the clinicians come in the room, the primary clinician is going to bring in the Lucas device, set it down to the side, and he's going to turn it on. He's then going to perform an assessment, doing a pulse check. Finding no pulse and the patient is apneic, he's going to lift the patient up and they're going to move them to the floor. The second clinician had already taken the Lucas board and slid it out on the floor. Once positioned on the board, the defibrillation pads can be placed on the patient's chest and lower left side. Once on, the analyze function should be depressed on the cardiac monitor. Next comes source control hood deployment. Now, the changes to the source control hood are the clear sheet should be already secured with clips on the PVC. Once the source control hood is on, then defibrillation or compressions can be done. The primary clinician grabs the Lucas device and then clips it over top the clear plastic onto the board of the Lucas device. It is then positioned and the plunger pushed down, and continuous compressions are now initiated and should be maintained until airway management can be done. If the patient is too big for the Lucas, manual compression should be done over the plastic. Now the clinician moves on to IO placement. He chooses the humeral access. The tibial access is acceptable site as well. Let's take a closer look to see what the other clinician is doing. He's preparing the equipment that the primary clinician is going to need for the next few steps of what's going on. So he's always a couple steps ahead. You've seen that he got the pressure bag and he's continuing with now medication setup. And after medication setup, he's probably going to move to his airway management tool setup. Okay, now 1 gram of calcium can be administered. He's going to say that's epi, but it is 1 gram of calcium is what he's actually administering.
1 gram of calcium going in.
So you can see the second clinician, he is now preparing all the airway devices and tube that the primary clinician is going to need to intubate. Okay, now he's going to move to intubate. He's going to tuck the back end of that clear sheet under the source control hood, and in a few seconds, he's actually going to call for a rhythm assessment. They're going to stop CPR. It's going to indicate a shock. They are going to continue the compressions through the defibrillation. Once the defibrillation is done, he realizes, oh, it's time for to give epi. So he's going to have to stand up and back up here for a few minutes, and he's going to call for his epi. Epi needs to be given in the shockable rhythm after the second counter shock, and it's at that time frame now. He grabs the epi, and he's going to administer 1 milligram of epinephrine.
1 milligram of epi.
Okay, now he's going to move back to his intubation. He's then going to position himself. He's going to take the ET tube holder and he's going to slide it under the back of the neck. It should be put in place early. Once it's in place, he will get the rest of his tools, the Intubrite, the tube, suctioning, the stylet. Now, intubation under the source control hood is going to be a challenge. You may have to tighten the plastic so that you can get a really good image of what's going on, but this is going to take some practice and some technique. This actually was a really good intubation considering the circumstances he's having to work under. A whopping roughly 29 to 30 seconds to achieve the intubation in this situation. So props to the clinician.
So I need to get a syringe for
So now he's going to begin the securing process of the tube. Inflate the cuff. He's going to secure the tube. You would do your lung sound check. You're going to make sure you got CO2 flowing. All those other checks can be done. So let's talk about that BVM a little bit. The mask to the patient, then the viral filter needs to be attached to the mask. Twisting the viral filter down when you're applying the mask is going to help it stay secure. It's important that that's done so that it doesn't come apart. Then the CO2 detector can be placed, and then it's attached to the BVM. It's important that we attach that CO2 detector after the viral filter so that that side stream sample has been filtered. This arrest management is only one example. Every situation will present its own challenges. Do your best for the patient and all the clinicians involved. The main priorities that we need to remember are: number one, do not rush into anything without first having your full PPE on. Number two, no compressions or defibrillations should be done without source control first. For us in EMS, that's the source control hood. But bystanders, that should be them putting a mask on the patient first. Hands-only resuscitation approach should be employed in their situation.